So I'm an orthopedic surgeon, and when I was a young orthopedic surgeon, I remember covering on-call for oncology in Stoke-on-Trent. And it used to be a separate ward away from where all the orthopedic on-call was. And I remember going and having a chat with one of the oncology registrars at the time, asking about the prognosis for some of the patients. I used to get asked to prescribe analgesia and sometimes whiskey or brandy or something for them. And when I asked about that, she said, well, they're all going to die. And that seemed very depressing to me at the time. I was younger, and I sort of thought, I don't want to do this oncology business. And as I was going through my training, I actually chose not to do sarcoma, even though the option was there. I just chose not to. I just blinded myself to it. And within a couple of years of becoming a consultant, I was setting up a service for patients with cancer. And it's now a third or more of my job. And it is the best third of my job, I think, because of the difference I can make in their lives compared to when I do joint replacements. And look, joint replacements I think is second only to cataract, particularly the hip replacement, in improving people's quality of life. So it is, it's very nice to see patients coming back, but it's also very nice to see some of the feedback that we get and knowing that we are streets ahead of the rest of the country in terms of managing these patients. That gives you a lot of satisfaction. Am I pointing there? Am I pointing correct? Yes. So I always start with this. I don't know why, a bit of morbid in me. So it used to be 1 in 4 of us when I first started talking about cancer. Within my career, I'm not that old, it's now become 1 in 2. And that's very significant, right? So we will have cancer in our families. One of us is going to get it. And this 80% is a bit contentious, as I found out yesterday, but the problem is ONS does not have the statistics for metastatic disease. And I've not made it up, it is there in some articles. And it is quite possible it's correct, actually. But a lot of cancer goes to bone. And we have about 375,000 new cases of cancer. And we know that we are keeping our patients alive for a lot longer now with the new therapies. So you can just imagine the prevalence of the disease. It is rising, it's rising big time. So we needed to do something, and this is our LIMS team, which has taken a lot of fighting, a lot of threatening, a lot of various other negative emotions to try and set up the service, because as you know, it's not easy. And we have some clinicians. These are orthopedic surgeons, upper limb orthopedic surgeons. Connor Fitzpatrick is our radiotherapy consultant for Clatterbridge, radiologists. Gemma is our secretary, and Sarah Messi is our tumor nurse specialist. She's amazing. If you ever use our service, this is the first person you'll come in contact with. Why do we need to do that? So before we set up this service, and this concept was really started by us, even though the guidelines were there since 2001, nobody was following them. So the tumor centers in the country, they recognize the importance and they know how to treat it correctly, but they can't deal with all of it. So they provide written guidance in terms of how to manage. But we weren't managing it well. The orthopedic surgeon's common tool is the intramedullary nail. As soon as you see a tumor, you shove a nail down the femur, and then think, and then find out, oh, that's not working. Oh, now we need to do something else. And sometimes, the tumor causes pain. We'll talk about that later. But the tumor causes pain for various different reasons. And if it is the secretion part of the pain pathway, because it's just creating, lots of leukotrienes, substance P, etc. Putting a nail down is not going to do anything at all. So they have an operation. We go, yes, we've done it. We made a really nice looking X-ray. Off you go. The patient's in pain. We've not really made them better because we weren't following them up. So we were noticing that the oncologists were basically just zapping everything that they could because that's what they could use and refer it to us when patients had fractures. And orthopedic surgeons were busy just nailing everything they could or doing hemiarthroplasties and then asking the oncologist if there was a problem, whereas it should be working together. And we started noticing problems with our practice because Royal Liverpool had quite a lot of cancer load in the hospital itself. There were a lot of primary organ departments there at the time. So we used to get a lot of referrals, ad hoc treatment decisions by whoever was on call on that day, and you ended up with a problem and then you have to revise that. Never works well in cancer patients, unfortunately. And we had more failures than we thought was correct. So we basically wanted to have a structured, methodical way of managing these patients. So me and one of my colleagues, Mr. Kumar, who's now left the service, unfortunately, for personal reasons, we were asked to set something up for the hospital. And I said to him, there's no point in doing it for the hospital. If we do it, we do it for the whole region, because that's the way everybody will be doing things in the next 5-10 years. So what we've wanted to do, and we're largely able to provide that, is to have a considered approach. Quite commonly, the problem was when faced with a problem, or the surgeons in general, they want to troubleshoot and they go, what can I do for this? And as soon as an X-ray is put up, there is an operation described immediately. Let's do that. And what we do is hit pause. We tell patients, we tell our colleagues not to list patients who come with metastatic disease and just call us, because that saves us from those patients being operated without having a good thought process behind it. And then we set about doing these. So what we're looking for is a single treatment that allows pain-free mobilization. If you ask a patient who's got metastatic disease, who's got cancer, they may have a prognosis, they may not. What do they want to do? They just want to be able to spend time with their family, do the things that they like, and not be in pain. If you are in constant pain 24/7, you just can't think of anything else, and that's no place to be. We wanted to set up an environment where we discuss this, so it's no good just me saying, I think you need this operation. We don't function like that these days, right? It has to be a discussion with the patient. Some of my patients go, I really don't want to have anything done, thanks very much. No, I don't want to know. And we of course inquire why they're saying that, but sometimes they have good enough reason and you have to say fair enough, it's your call. But we don't see them in a fracture clinic. We don't see it in a place where there is a lot of activity, a lot of noise. So we have an elective clinic where we do our clinics. It's a 40-minute new consultation, which is unheard of these days, right? I think as GPs you do 10 minutes in which you not only get the diagnosis, you fill up all the things. My wife's a GP, so I know very well. And then refer the patient somewhere as well in those 10 minutes. It's not doable, and you know it. So 30 minutes with me and 10 minutes with the nurse specialist, who will then ask further questions as to whether they've understood everything, what are their fears, which is quite commonly something that drives what we'll do for them, right? So quite often they go, well, I fear just ending up in a wheelchair. Will I be able to walk after this? You've described an operation which is, no bone, all metal. How can people walk with that? Even though I would have explained to them, shown them images of other patients, we don't often show them videos, but you can show the X-rays of other patients who've had those kind of operations. They look at it and they won't ask me, no, but I'll never be able to walk with that. They'll be too polite. But they'll tell Sarah afterwards, I don't think you can walk with that, right? Your total femur replacement, how can people walk with that? So she will give them more detailed explanations, etc. Find out whether they need psychology services. Every, 5 to 10% of our patients, I think, require input, either because they're in total denial, or they will actually raise the point themselves as to what they're concerned about. Quite often it's what's going to happen to the kids, because a lot of our patients now are in their late 30s, early 40s with breast cancer. And common concerns are, if I haven't told my kids yet, if I come in for an operation, they're going to find out. These are things that need to be dealt with. We have a lot of information leaflets to explain to patients after they've gone home, and they have a single point of contact liaison. And that's the most important thing that we as clinicians can't give. So we have a tumor specialist nurse who, is constantly receiving texts from patients, answering their questions or escalating it to us to give the answer that is required. And that's very nice for you, right? Have you ever tried to call all the hay for your kids if they're having a procedure or an appointment? It's impossible to get through the right person. And I get rage when I'm trying to do that on the phone because I just can't get through. Isn't it nice for them to have a single phone number, a mobile phone number, we can just text? You know, I've got an appointment on Friday, I can't come. That's it, that's all they need to do. They don't have to call 5 phone calls to sort their appointment. And we wanted to make sure there is follow-up. So a lot of the times, you'd expect clinicians to do surgical operations and follow patients up. But metastatic patients, unfortunately, were not being followed up. You know, they'll be operated on, nobody has an interest. They go into the fracture clinic and the junior-most member of the team is making decisions, and quite often, even if things have not worked out well, we haven't learned from it. So we don't discharge our patients. We follow them up until they don't want follow-up. And it's not always bring them back to the clinic. So we were doing patient-initiated follow-up before it came on a couple of years ago. And particularly patients who come referred from far away areas, there's no point of them coming, so they have local x-rays and then we just call them up and ask them. We can get all the information we need from telephone calls. And education, so it was very important for us to make sure that what we're doing is passed on and it is made the norm almost, because we knew that was the correct thing to do. We found it very difficult to I wouldn't say educate, I wouldn't convince our colleagues, some of our older colleagues. And we basically provided them with the option that, you know, we'll take over the patients and we'll manage them. You just refer them to us and we'll sort it all out. It took a while, but currently, certainly majority of the Cheshire Merseyside, we are actually functioning at a way higher level than the rest of the country because we are a very cohesive service. People are allowed to dial in and speak about their patients, ask for advice, and quite often treat them locally. So we didn't want to take over the care, even though that was mooted at one point. It makes sense for these patients to be treated closer to where they are, because it takes a long time for somebody to come up from Leighton or Macclesfield to come and see us. So ideally, everybody, and look, surgical part of all of this is very simple. So you might think these are complicated operations, they're not really. What I do is not complex. It's just the decision making, and that's where you get it right if you have a truly an MDT approach. So, you know, and you can't be one person doing it, because I myself, even now after 10 years of doing this, I'll say I think we should do this, and my colleague will go, hang on, but what do you think of this? And you go, yeah, that's a good idea, you're right. And it cannot be one person doing it. It has to be truly an MDT approach in decision making, because that's the most important thing. So we present our data regularly. We teach the juniors. I teach at a BOA masterclass, which is exiting trainees as they're becoming consultant. That's the best time to catch them to change practice rather than trying to teach consultants. And we have networking meetings where we regularly, all the interested consultants in the region, I organize a 2-yearly meeting. 1 year is too quick, but every 2 years we meet up to share the knowledge that we've gained. And it's very interesting. We keep on changing our practice on a regular basis. Within my own 10 years of practice, I've changed quite a few things because immune therapy has changed the game completely. We've recognized a lot of things that we could manage non-operatively that we used to operate before, because we've got the data. So we look at our data and we learn from it. So things that we do differently. It is very clear in the literature, it has been for about 20 years, that if you operate on patients before the fracture, their outcome's better. It makes sense, right? You know, you have tumor, you have a fracture, the tumor spills out, and you're going to have, apart from the other, you know, the catastrophic event and all the downsides from it emotionally, the tumor spillage makes the outcome worse. We knew it for a long time, but we weren't following it. So we have very low rates of pathological fractures in our region when we compare it to other centers. And it's largely because, what I'll show you later, we get a lot of referrals from Clatterbridge before they start on radiotherapy. and they'll ask, do you think you can offer a surgical procedure? And if we can, we'll do that, and then use radiotherapy. And it isn't that we're operating on more people than need to be operated on. We're just doing one operation, and they don't need further surgeries. And after that first operation, the quality of life is good. It's very good, because we're choosing options which make them pain-free. So if we have somebody who is expected to be alive for 5 to 6 years, we generally won't choose an intralesional operation, because that will still leave them possibility of tumor progression or further pain, for example. So we'll quite often go for an excisional, which is an endoprosthetic replacement. And that will mean that tumor from that side is gone. Now, theoretically, it's possible there'll be more spread in the lower part of the femur, for example, but it doesn't happen practically. Whereas if somebody has got a low life expectancy, it doesn't make sense to do a big operation for them, which will take them weeks to recover from, and they have an iron nail. So endoprosthetic replacements, they have very good, robust outcomes, whereas plate fixations like that, iron nail, somewhere in between. And that's because endoprosthetic replacement is an excisional operation. You remove the tumor, whereas the nail is an intralesional, where the tumor is there. And as soon as there is a bit of escape from treatment, it will cause havoc again. So some examples, we love x-rays. I can't have a talk without x-rays. So that's one way. So 84-year-old man who's come in for a scan of his chest and abdomen, because the GP suspects some tumor in a urothelial region, because he's got blood in his urine. So fairly clear, but he falls on his way out. He had no hip pain before this, and there is a lesion here, but it's a little bit hidden, but for most orthopedic surgeons, we should be able to catch that. So this patient has this presented in trauma meeting, and they have a hemiarthroplasty done, because they've now got renal cancer. They're not going to live long, so you just do a hemiarthroplasty. The trouble is, between that X-ray on the left and this one on the right, he's been to his GP 6 times in 18 months, complaining of pain. And this X-ray is quite dramatic. You can see the bone is being eroded away, but the intervening X-rays were not as bad. So they were being reported as normal. There is a hemiarthroplasty in place, normal. And even if you're a very astute GP, quite often you don't even get to see the X-rays. You're just getting a report. And if a radiologist is saying normal, you go, okay, there must be another cause. Maybe it's the spine, maybe it's something else. It can't be the hip. But this is what was going on. So 2 years later, he's still alive. He's not died yet. And we have to do something. So we ended up doing a proximal femur replacement for him. This is what's changed in the last 5-6 years. Advanced renal cancer. So overall survival previously used to be 29% of them would survive 5 months. Right? Currently, at 18 months, 75% of them are still alive. That's a massive difference. So you can well imagine the number of patients with this disease who are now requiring different interventions, because you can't just use the basic things that we used to use before, because you're going to have to do 2 or maybe 3 operations if you carry on doing that. So you've got to change. You've got to be light on your feet. Here we have a 58-year-old with non-small cell lung cancer. So these cancers have very good survival these days. 5 to 6 years is not uncommon. So she's referred to us on a Tuesday. We'll see her on Friday to discuss a big operation. You can see the tumor is going below the level of the lesser trochanter, and to us that means in somebody with good prognosis, you can't just nail it. You can't do a hemiarthroplasty or a total hip replacement. It has to be an excision and a prosthetic replacement. So she ends up in another unit on Thursday night, because she has actually fractured through here. So we convey to the treating unit that we were planning to do an endoprosthetic replacement, and that unit does do those kind of surgeries. But the consultant on call obviously, is the decision-making person. He didn't agree with that. So she has a simple total hip replacement, and this X-ray is 3 weeks after the procedure was done. You can see the gap there already. The bone is, that gap is not because something's moving, it's because the bone is dying, the tumor is expanding. So the pain's getting worse, so there's no plan to use radiotherapy like we would at 3.5 weeks. No plan, right? So we've just seen the patient, there is a problem. We will refer to oncologists now because there isn't an MDT process. That referral is gone by paper or an email to be received somewhere. And then she's seen at another 3-week mark from there, 4 weeks nearly, with a painful hip, which the radiotherapy consultant who's with us in the MDT goes, it doesn't happen with our patients normally. Why is she in pain? She's in pain because the tumor is progressing. So we've got to do something. So we recommend that she should have this procedure, which is a proximal femur replacement. That's what she should have the first time. So that procedure is now performed. But we know that when we do revision operations for these patients, the risk of infection is about 17%. If you do first time, the infection rate is about 1% in our series. So she gets, and she gets wound leakage, so we stop the fragment. That's quite common after revision surgery. And because the fragment stops, she gets a massive DVT from the leg to the pelvis. She comes in to Clatterbridge with fever. I think that was just because of her massive DVT. But there was leakage, so we worried about infected EPR. She's got blood cultures positive for Staph hominis in a couple of days. So she needs a washout procedure, which is now the 3rd operation. And we know that we can't really get rid of the infection. She's immunocompromised, and she needs an IVC filter. And in the end, from what was meant to be a 6 to 7 year survival, she passed away in 6 months because she never reached a stage where she could be considered ready for immune therapy. Because remember, you've got to be performance score 1 or 2 to be given a lot of the immune therapy, because that's the way the trials have been done and that's the way the guidance is. So you've got to be a mobilizing person before you get those. So she wasn't mobilizing, so she didn't get that treatment. And she had infection as well, so she couldn't start off. So that's an example of how things can be, and that was very common pre-2013. Here's another example. So patients got, this is, I agree, not very easy to see, but there is permeative disease here. She had a lot of pain, breast cancer, quite young. And we don't treat these with radiation. We stabilize them. Even if we're not doing an endoprosthetic, if we would use radiotherapy after stabilizing the bone, because once you use radiotherapy, the fractures don't heal. But for some reason, which we never really found out why, the oncologists recommended using radiotherapy. So a month later, she gets a fracture, which is then treated with an iron nail, but that fracture is never going to unite. And the metalwork is starting to fail. So the way we do it, hit pause, think, investigate the patient. So you need to know what you're treating. There are instances where people, without knowing what actual primary tumor they're treating, they would go on and nail the femur. That's not appropriate. So we have liaison with radiology and oncology. We want to create a construct. So if somebody is 80 years old and they've got advanced cancer, if the only successful biomechanical construct is going to be an endoprosthetic replacement, then that's what we'll do for her. Because just because she's elderly and may not have very long to live, doesn't mean that you just put a nail down which will not control her pain. You've done a useless operation for that patient. Of course, you have to weigh up, are they going to survive the procedure? Do they want to have that procedure? But we'll either do nothing or we will do what is appropriate, because it needs to be a single operation. That's the most important thing for them. And after discussion with the patient, of course, and execution of the plan, and more importantly, consistent post-op care. And that's what I think we do well, because we're structured. At 2-week mark, we'll see the patients, make sure that their wound is healed, and now we can go further. So we'll contact the oncologist and go, yeah, green light, go with the treatment. Radiotherapy is discussed the same day we see them in the clinic. We discuss it with the radiotherapy consultant, and he'll say, okay, I'll book him in a week or 2 weeks. If the wound is not healed, we wait. But that is the plan. Whereas if you don't have these kind of setups, you will refer for radiotherapy, and it might not happen in time. the oncology treatment might not start in time, and you're losing out tumor control. An endoprosthetic replacement is a very effective way, and it has low complications. So because we now do these in big numbers, we've been publishing our work as well, we can now say that the rates of infection that used to be considered before 10 to 14% is not the case. It's very low. Things that go wrong with these are very, very uncommon. So based on that, we can now offer these big operations to patients. So a similar patient, really, renal cell, and they're presented with this fracture. He's younger, he's 53. And so because he was referred to us, he has a CT scan which shows a massive lesion. But you can see there's something going on. So we go, hang on, radiologist, what do you think's going on? He goes, yep, there is a lesion there. We need to do, and then there is renal cancer found as well. So we embolize this. If you go in treating renal cancer, you end up in a bloodbath. They can lose about 1.5 liters in 5 minutes. So the primary. You will now go and embolize this tumor, which will reduce the chances of you causing massive bleeding. And this is what it ends up with. And this is him going on his first holiday after his diagnosis in 4 months' time with his wife to Lake District. He was really pleased at that point. That's what I want to do if I had metastatic cancer, right? You'd want, fair enough, find out how you can treat me. Do I have to stay here? Is it regular weekly visits for chemotherapy, etc.? But I want to spend some quality time with my family once I've found that diagnosis. And if you have, like the previous patient I showed you who had a hemiarthroplasty but constant visits to the GP, I bet he wasn't going on holiday. Right? He was taking loads and loads of painkillers and constantly trying to get in touch with the GP so he can have some more. And because of what we're doing, because of what the oncologists are seeing with our method, our numbers are rising. So this is where we were some time ago, 2018, and this is where we are last year. This is actually unsustainable the way it is now. Referral sources, so we get, so this is, these numbers are for 21 months. We've only chosen that because that's the time when my tumor nurse specialist started, so we wanted to see what things are like after she started. And nearly 300 referrals a year from the oncologist Clatterbridge, 72 from within the hospital, and then 81 referrals from other hospital trusts in the region. But the big thing is, 60% of the total number that we've treated so far is in the last 21 months. That's amazing. It's an 11-year history. So about 375 procedures, reasonably equal mix of nailings, endoprosthetic replacements, arthroplasty. What we're doing well, so we are able to do a single operation that alleviates the pain and allows them to mobilize full weight bearing. If there is something that would require them to be partial weight bearing, protected, that option is not chosen. That's bend. We've got to do an operation, however big it is, to allow them to weight bear and mobilize freely. So that's interesting. Now, we used to say, these are big operations, they're complications. Revision for all cause, 0.9% for joint replacement kind of patients. Infection rate, 0.9%. Infection rate for all procedures, 0.5%. These are patients who have immune compromise. These are quite sometimes elderly patients. This data is better than a lot of people's elective joint replacement data. Now, it's not that we're good surgeons, that's why we got these results. It's not, we're average surgeons, most of us are, by the Bell's curve. The reason why we got good results is because we've got a structured system. We've got an MDT approach. And that's why, and we've seen it from a number of other examples in healthcare, right? When you centralize things, when you have people who are interested in doing something and there is more than one person doing it, there is discussion before something's done, outcomes are better. Oh, I forgot to tell you about the OF. So before then, when we choose an intermediary nail, You've just seen that we do quite a few of them. It's not that we don't use them. We've never needed to revise one because of tumor progression. So clearly we've chosen correctly, and those patients are ones that don't live very long. And you know, they are not in a situation where their pain is not controlled, their disease is progressed, so you have to go on and do an endoprosthetic replacement from then onwards. We've never done a single one in the last 11 years. And whenever you're doing pathological fractures or other tumors, there's always a risk that you could actually operate on a sarcoma or a primary bone tumor. This is something we don't want to do. So we don't deal with primary bone tumors here. We used to call them whoops procedure. I don't know whether you remember from reading it in books. So we call them OF procedure, which is oh fuck procedure. So that's what you say when you do something like that. None. You know, we haven't done that yet. And of course, we refer. Whenever there is a query, there is a primary bone tumor or there is sarcoma, we will refer. We send quite a few patients to Oswestry, some to Birmingham, very good relationships with them, because that's appropriate. So it's not that we're surgeons, we like to operate. I don't know how well you can see it, but you know, I think it's pretty clear there is no bone there, right, on the superior ramus. There's a big hole. The CT scan is even more scary. And I used to do total hip replacements for these patients with large dollops of cement because there's big holes there. But then we realized, you know, having missed a patient, so my colleague, spinal surgeon Marcus Dematis, once sent me a patient who saw a big hole in his pelvis and, oh shit, he was seen by a fellow 3 months ago, and the fellow missed that because he was concentrating on the spine. So he said, what are you going to do with this now? And it ended up being a big operation. Well, the guy, 3 months later, he said, well, I had a lot of pain. I'm actually getting better. So I said, all right, you still have a hole in your pelvis, but we're not going to operate. Let's just wait and watch. We're going to x-ray again in 3 weeks. So the x-ray hasn't gone into protrusio. It's still maintaining its shape. X-ray again in 6 weeks. It's still okay. And then we realized that when these patients are on correct treatment and they're on bone protection, denosumab, or if they have radiotherapy, then they actually, the disease progression halts. And then the bone is always going to do what it does best. It wants to heal. So we have a series that this is a series we presented last year at Booth, 24 patients with non-operative treatment. And there are still a lot of surgeons who are actually filling up these holes and doing big hip replacements. And you know, we constantly, whenever we get a referral, we go, no, don't have to do anything. Just start the treatment and let's see how they are. So this patient has actually had some collapse, which is very likely given that, but he's still not had a hip replacement yet. He's a bit short, wears a shoe raise, and goes, I'm all right for now. You know, his treatment's been so good that we are treating him as, he's about 52 odd, and we don't like doing joint replacement in young people. So he said, well, I'm all right, you know, I'll have it done when it's really sore. This is the patient that I was telling you about. So that hole was missed by a fellow. And eventually, a year later, you can't even see that hole. It's actually normal trabecular bone almost. No surgery. Another bugbear of ours is a lot of people see a hole and they go, okay, we do an operation for that. So we've actually published on this as well. So whenever we do any kind of operation on one part of the bone, we image the rest of it to make sure there isn't anything going on. So this lady has got a lesion. This is lung CA. And if you go further down, this is somewhere at this level here. So there is another lesion there. If you do a simple hip replacement, which is halfway to there, she will then fracture further down, or she'll have pain. So what we do is we curate it out and plate the whole of the femur. So she's had one operation and everything's sorted now. So why have we had such good outcomes? You can argue streak of fortune. We know it's not that. We've taken time to acquire knowledge about different tumors, and they all behave differently. We will do different things to renal and thyroid than we will to breast and prostate, because those are more easily manageable tumors. They're slow-growing ones. We do listen to the oncologists when they tell us whether the tumor is ER, HR positive or not, whether it's responding or not. So the responders for breast We have a big series of intralesional hip replacements where we haven't excised, because these are very young patients, remember. And if you do an endoprosthetic replacement, the function is definitely poorer than if they have a hip replacement. So from our own results, we can actually show that if you have a responding breast cancer, then you can just do a simple hip replacement, and we've not had to revise one of them yet. We have the option of doing an endoprosthetic later if the tumor progresses, but in 10 years, we've not needed to do that. We want to get it right first time, particularly when you have this longer period where you have results are like this. We're now extra careful. We want to be really careful that none of our patients need to have a revision. The important thing also is the consistency in approach. So, all of our patients, if they're on chemotherapy, they'll stop 2 weeks, they'll have a blood test, they'll have the wound check, they'll have the communication to the oncologist, and everybody knows this circle. So they won't jump it. They won't start treatment at 2-week mark until we've said so. And if they have done once or twice, and they get a letter to say please don't, because there needs to be consistency in management. And because everybody understands at what stage we're doing things, there usually aren't problems. We collect data, so every patient's gone through the service has the data collected, and we follow our patients indefinitely. Whether it's just with phone calls or they have a patient-initiated follow-up. So we know what's happening to them. And we had very supportive colleagues. So even though we sort of took work away from them, said, well, we're going to do this, they were actually very happy to let us. It isn't the case in every place. So a little bit about patients in the primary care setting now. So we have examples like these, at least 3 to 4 every year. Now, and it was something like what I spoke to you about earlier. So this patient's got a left hip pain. I don't know whether you can see that lesion there. I think it's visible, right? And when so this was a big problem, and I had to sit the patient and her husband down afterwards. And when I was showing them the x-rays, which was reported as normal, right? Both hip joints preserved. He went, oh, that's not right. The husband is a plumber. And you can't argue with that. It is very visible. But as a GP, you've sent a patient because they've got hip pain. You get a report saying it's normal. What are you going to do? You can't. So this is where we need to do some more work on. But there are things. So whenever you have a patient who says, I'm in pain at rest, this gnawing, constant pain, it just doesn't go away, and you move their hip, that doesn't make their pain worse. It's just there. There's something going on, right? Unless you have somebody who's a malingerer who constantly, you know that, right? When you see the patients, you know which ones come every 6 weeks and some that you've never seen, and then suddenly they're complaining of a lot of pain, they're asking for more and more escalation. You can't sit back with that. I know you're always safety net, but what will you do if the report comes back as nothing? So you might say you have limited access to scanning. A lot of you can't request all the scans that you want. Which service do you send them in? It isn't easy, right? Up until very recently, we didn't have anything that would take this. Now we have a non-specific cancer service, which you should utilize if you have somebody has got cancer or you have very high suspicion of. Then non-specific cancer service will take them and investigate. But this patient had that. So she went for 6 or 8 weeks with this complaint, and eventually this GP service was able to request MR scans. So she had an MR scan. It's very interesting. An addendum has been added. So this person has seen the MR scan. I think they have been told at that point that the patient had a lesion. So they've added an addendum to the X-ray report saying that this patient has a neck lesion. But they had to put the date on that, and that date is when the scan was done. Right? So that's the scan. And they are very unhappy. So I think they're in process of taking legal action. They're very upset. I don't know what they'll do. And I've written to the radiology department of that particular hospital to say, can you please have a meeting with the patient? They have some questions. But they're right. This isn't good service. And this is, a first world country. Is there a problem with reporting? Yes, there is. Is there a big problem with reporting in general? Yes, there is. You know, we have so many cases to report. I know AI will probably help a lot of this, but we can't rest at that. We need to have something in place where if as a GP you referred somebody and they've been reported as normal, now you haven't got anywhere to go, there still should be another way to follow that up somewhere. Because you will know when you see a patient there's something going on. You know, you can't just turn them back. And I know this happens. I've faced that personally. Another patient who's got pain in her hip, and she's been multiple times to the GP. Now these are, I accept this is not easy to see, the one on the left, but I know there are multiple small lesions there. There's one over there. But of course, an orthopedic surgeon interested in metastatic cancer is not going to see all of these x-rays. But there's, with the correct history in somebody who's got the correct age, myeloma should have been thought of here. But she waits for another 3 months before this x-ray is performed, which shows a massive lesion. So she has an appropriate surgical procedure. She's doing well. So we have a lot of issues with our service still. We haven't quite got it sorted. We don't have a dedicated physiotherapist working with us, which is NHS England requirement for any cancer service. And it's very easy to see how it'll be amazing, but we don't have funding for that. There are a lot of things that we need to do. So one of the things we've noted more recently is patients coming with big lesions in the subtropical region. We used to practically always nail them at that point because they're likely to proceed. But with immune therapy, we're now seeing that within 6 to 8 weeks of start of therapy, the next interval scan, which usually happens about 3 months, those lesions, they become more sclerotic and they become less painful. So we've had 2 patients cancelled on the day of surgery because their pains got better. And obviously, that will reduce the number of patients we operate on, although we don't know actually exactly which ones we should or not. When you have a lesion in the bone, we worry about a fracture, and sometimes it's easy because they've got pain. Pain generally means that the periosteum is being stressed, which means that the bone, the cortices are just not strong enough to take the stress there, so you're getting the pain from the periosteal nerves. But when they don't have that much pain, what should you do with them? You can always keep an eye on them, but that's very labor intensive. Do you operate? Do you not? And I think that's something that we're working on with somebody across in the US to help us with the conservatively managed patients who've not progressed or not progressed quickly enough to see whether they can tell us if you have X percentage of the surface area involved, volume involved, you're likely to get a fracture or not. And I think this is my next challenge, I think. So once the service and the funding, etc., is sorted, we need to improve the primary care guidance, I think, which is lacking. For sarcoma, you have very nice, clear-cut guidance, what you need to do as soon as you encounter swellings. For metastatic disease, there isn't. And from the second slide, we know that these numbers are rising. They're going to rise big time until, we think, till 2040, when we'll start to get reduction in total cancer numbers. So there is still a generation of surgeons and GPs who will face this rapidly rising problem, and we'll have these patients to deal with that we don't exactly have a good algorithm for. So we need to develop. It's not very difficult to develop it. And I do, when I go around, I do some private practice as well, and one of the things you have to do with that is go around to GP surgeries and you give talks, because your private hospital provider won't let you off without that. And I don't talk a lot about hip replacements there because there isn't a lot to talk about there. Right? If you have a painful hip, you have a hip replacement. So I do talk about metastatic disease because a lot of my GP colleagues will go, well, what do you do with somebody like that? And yes, education and guidance is good, but we have to get past some problems, that some fences that we've created around the primary care. Well, you can't see hospital notes directly, you can't see the x-rays directly, you can't request a CT scan or an MR scan, because you don't know what you're doing. That is stupid. But if we are going to follow that, then there needs to be something that gives. So if you're requesting this X-ray second time for a patient who is in pain and has not got better, then that X-ray has got to be reported by a senior radiologist, or there's got to be something there to go, okay, please have a look at this. You can't be the same junior person reporting that X-ray. There needs to be some work done on that. After I got funding for my service. So the problem is, we are currently being told that because we're taking up so much resource, and a lot of these surgical cases are rising, so trauma gets affected by my cases. I go, well, elective work gets affected because people who are fit enough to have a hip replacement, they come onto a broad green side for elective hip replacements. So my manager is going, well, there's no funding for it and you're taking up a lot of resource. We can't let you have this or that. So working on it. Wish me luck. But the best part of the work is this. I don't know whether you can read it, but so we collect feedback from our patients with the Envoy service that we have in the hospital. And they aren't all perfect. There are problems, and problems often come from the ward where patients probably don't get enough analgesia when they need it, or they can't go home when they want to. There's delays in discharge or whatever. But a lot of them are very complimentary of our tumor nurse specialist, Sarah. She is just amazing. She was a sarcoma tumor nurse specialist before, and she's come and joined us now. And it feels good that at a very difficult time in our patients' lives, we're able to make a difference. That's me.
I've got a question.
Sure.
What do you do if the patient's not fit for surgery? Because I'm thinking about my poor neighbour of mine who was only 60, had a breast cancer that she didn't know she had, and had a pathological femoral fracture.
Yeah.
And they said she was unfit for surgery due to some heart failure, and she was quite obese. And she basically got sent home to die and laid in bed for 6 months, which I thought was really awful. So what do you do in that situation?
Yeah, so there isn't a right or wrong answer. So we are as a team very aggressive, because we know this is what can happen often. And some of our patients don't want to have an operation initially, and they think they're dying. And 4 weeks later, they'll call in and go, can I have this operation, please? Because they're just still there and they're in pain. So my gut feeling would be to offer surgery as long as the patient understands the risks. And they might initially say, no, I think I want to go back home. I want to see all my extended family, say goodbye to them. And on the second week, they might say, okay, now I can't take this anymore. So that's one option. And I will operate on them as long as I'm allowed to. Radiotherapy is an option, which is very poor. So you're talking about pathological fracture. If they have a lesion which hasn't fractured yet, then certainly radiotherapy is a good option. The Macmillan team will do whatever they can, along with our chronic pain team specialists, to provide them with as good a relief as they can if they're not fit for surgery. But there aren't too many options, which is why the aim should be, I think, to catch them before they've actually fractured. And we can then do simpler surgery, which is a much better option.
Yeah, unfortunately. She didn't know it was there, and then she fell on the stairs and pathological fracture. And
absolutely.
Yeah,
and look, we don't have an answer for all of these difficult questions. Yesterday at one of the metastatic leaders meeting at Cardiff, the oncogeriatricians were suggesting, so there's going to be work done now on frailty scores, and we will try to understand what level of frailty we should just not offer surgery anymore. And 9 is easy because you're close to dying. But do you say 7 or 8 that should not have surgery? It's very difficult. So our approach is, so it's been shown, one part is a humane side of things, the other part is costing. Right? So it was shown in 2002 that keeping a patient comfortable costs about £4,000 a month if they've not been surgically treated. This is 2002, done in UK. And that would be 4 times that amount, because it costs a lot of money for the Macmillan visits, for pain relief, for various interventions that you try and do, and the quality of life is rubbish. So wherever possible, we try to operate. It does mean that I personally will have a slightly higher mortality rate on my data for joint replacements, but I'm allowed that.
Thank you. Any questions? Kate?
I think it's really interesting that our hospitals are literally physically adjoining, and we've never met before until today, until just before this meeting, and we literally have parallel services that are facing the same issues. But the big thing that strikes me is how the metastatic setting now is a completely different world. Previously, 10 years ago, patients who had metastatic cancer, their prognosis was poor. What we're talking about is our population living with cancer, and these are the cancer complications that they have to live with. So it's very difficult to tailor our service, like you say, having the commissioning conversations, but actually that's the reality where we're at. A lot of our patients, a lot of our people are going to be living with their cancer for a long time, and we have to have a better way of joining up these services. We literally are physically connected and don't know about each other's services. So it just shows how...
Well, I know about your service very well for quite some time.
But we're not connected. We haven't been connected until today. And I think that's a really good example of how, occasions like this, that's the whole point of the network, and in connecting people is because we get an opportunity to disseminate and share. So I'm looking forward to it.
Absolutely, absolutely.
That's good.
Thank you very much. You mentioned about the psychological support for the patients. So do these patients have a fast-track service to psychological services, or does it delay their care, or if they need psychological services?
I don't think it delays the care. So
the model which you have, because everywhere else in the country there's a long waiting time for see a psychologist.
No, there isn't.
So from your model,
so cancer patients in Liverpool, at least, they're served very well for that. Most of our patients would have seen a psychologist within about a week. That's amazing. So that was set up some time ago. So that was being utilized for the sarcoma service, and they basically offered their services to us as well. We don't utilize it a lot, but when we do, it's a very rapid conversation with the patient initially, and then they get brought in. Quite often it is not more than a conversation. It's making people understand that they have options. People speak about their fears, and that's what helps even themselves, right? That's true with all of us, right? When we talk about something, it helps us. We're not geared up to provide that service as clinicians. I'd be rubbish at that. But we have the option, and we use it wherever we can. It doesn't delay treatment. Most of these patients are actually not saying that they won't have surgery because they're really scared. They will come and tell Sarah various things about what they're worried about, and that's will spark off. And she's well trained in this to recognize, and she'll just spark off a conversation outside of the room. Go, hang on, I think this patient needs to be referred, and we'll do that.
And second question is, with regards to the prosthetic replacements, are they mobilizing same day, or is there any like a few days bed rest, or? So
there's no bed rest, but there is a difference between hip replacements and endoprosthetic replacements. So my hip replacements go home the next day, and then that's pretty normal these days. For the endoprosthetic, they will have an externally rotated leg, which we use a trough to make sure that we keep it neutral for the first 3 weeks. They'll walk the next day, but they will not be able to control the leg in space very well until about week 3. So they need a lot more rehab.
So it's like a non-weight bearing, or?
No, fully weight bearing. They're fully weight bearing. They're able to get up and walk about with a Zimmer frame, but they're very uncomfortable. And that delays the discharge, because if they're not confident enough to walk around in the house themselves, then they won't we can't discharge them. So our length of stay used to be 13 days. Now it's come down to 7 days average over over the last 7 to 8 years between the two times that we measured it. I think that's probably our physiotherapists having seen a lot more of these. We're using a lot more endoprosthetic now, not only for metastatic disease, but for revision hip replacements and periprosthetic fractures as well. So the problem where we do face is when these patients are referred out. So, you know, if they're being seen at Liverpool, if they go out to Southport. I've had some patients from Southport, someone from Wales come back with a total femur replacement. We was told, well, you can stand up and you can go to the loo. Well, that's more than what you should be able to do with this. You haven't got any femur left. And the guy didn't listen to them. He was 85, and he basically got himself a rollator and used to walk outside the house himself. So by the time he came to see me at 3 months, he said, I had no physio, but I'm all right. I can go to Sainsbury. And that was just him. But yes, and one of my patients, 83-year-old esophageal CA, had an endoprosthetic replacement. He ran on the banks of Wallasey because he had a bet with his son that he was going to do it. I think they ran about 100 meters or something. So it can be done. And you know, the patient that I saw a video of, right? I mean, this guy is walking pretty much, he's got a bit of a limp, but he's walking very well without any aids. And that's the norm for most of our patients.
Sorry, last one, sorry. With regards to the hole in the hip patients, is there a difference in quality of life of patients who have had surgery and the patients who haven't had surgery?
So they've got a metastatic disease and they haven't had an operation yet.
No, the one which has the hole in the...
oh, you mean myeloma patients?
Yeah.
Yeah. Eventually, no. Eventually, no. Well, but they can have the complications of surgery. Yeah, so hip replacement is not without its possible complications. And if you don't have to operate on them, I know what I'll choose. But the problem is that we didn't actually know this until a lot of us have started highlighting this. Because a lot of the times, because there weren't these kind of converged services seeing a lot of a group of patients, everybody would see one or two and they won't actually connect it. But now we can. So we now realize we don't have to operate on most of these patients. So eventually their outcome is just as good as a hip replacement once the bone is healed, you know, the trabecular patterns are formed.
Thank you very much.